Hey guys, this is Pete. I wanted to give you all a quick refresher on the fascial compartment block. First off, just wanted to say good job because over the last couple months there's been a significant uptick in the amount of these that we've been doing, and a number two to three of the ortho attendings have come down and actually said how impressive that this was, that we were doing this and we're really making a difference in patient care. More than that, I've had one of the internal medicine hospitalists ask if they could learn how to do that because, as you guys know, that they get calls about these patients when they're admitted and they get a medicine consult. So oftentimes the internal medicine doctors have to manage the pain, and we're actually saving them some time and effort and making their job a little bit easier by doing these blocks. So good job with these. So again, what is this block? It's a compartment block. It's not an isolated nerve block. It has the added benefit of having the same efficacy as an isolated femoral nerve block without all the complications. It's safer, it's easy to teach. You're not doing it near the nerve or into the nerve. You're away from the nerve in the compartment that is adjacent to the femoral bundle, and it is less time consuming than a isolated femoral nerve block. Who are we doing this for? All of our hip fracture patients, which here in Maine is and are abundant, and we're not in short supply. When I see a hip pain flash on Epic, I reflexively will order bupivacaine as well as Tylenol, ensuring they don't have an allergy, of course, and that way the nurse will get the medications, and by the time we're ready to go, everything's set. So how are we doing this? Basic ingredients: 2 syringes, a large 30cc syringe, which will be full, and an insulin syringe, which is for your small skin wheel. Usually this, I'll just grab the lidocaine that's up on the shelf in the clean utility room, fill an insulin syringe, go in with my probe, mark out the anatomy and where I'm going to be entering the skin with the LP needle. Do this, fill up my 30cc syringe with typically 20 cc's of bupivacaine and 10 cc's of saline. This will give a nice 30 cc aliquot, volume aliquot, that you can instill into the fascia iliaca compartment, which we'll go over. In general, I'm doing this with a ChloraPrep in the same way we're doing IV starts. This is sufficient. I don't think there's any data or indication to be using gowns or sterile gloves. Just be respectful and clean in the area, and there should be no issues there. So how are we doing this? In general, again, 20 cc's will give you 100 milligrams of bupivacaine. The safe dose is 2 mg per kg or less. So 100 milligrams for a 50 kilogram person is safe. Anyone more than that, you can use your 20 cc's, or if you're actually 75 kilograms, which a lot of our patients are, you can be using a full 30 cc syringe of bupivacaine. But in general, to make it easy, 20 cc's of bupivacaine, 10 cc's of saline. Onset, 20-30 minutes. Duration, 6 to 12 hours. Where are we doing this? In general, just where we're going to be putting in central lines. So right in the femoral bundle, right along the inguinal ligament, is where you're going to be orienting your probe. And this is your anatomy that you're going to be seeing with your ultrasound. Here it is in real time, top of the screen. This is the right leg with the corresponding right ultrasound image. You can see in the middle of your screen here is your femoral nerve. Here's your artery. Here's your vein. Nerve, artery, vein. Okay. Fascial iliaca compartment is this darker area here. See how nice and generous the target is? I'll usually just get this view, move my probe laterally so that all you see is your nerve, which will then be on the right side of your ultrasound image, and it'll give you a huge target, and you won't be anywhere near your vessels. So start here, move your probe over, and then you're going to inject. On this image, so again, this is really important, is that your fascia lata here is the top fascial layer, as well as your fascia iliaca is your bottom. You need to pierce through both of these to have an effective block. If you go through just one, you won't have any pain relief. So if you're ever unsure, which you shouldn't be because you're using ultrasound guidance, but just make sure that you pierce deep enough through your fascial layers. You get a sense on the side of how deep you're going to be. So with your needle, you should know if you're deep enough. And you should be visualizing the needle the entire time. That's why we're using the LP needle. So in this image, this is actually the left side of the patient. The last one was the right femoral bundle. Here's the left femoral bundle. Again, nerve in the middle of your screen. Here's your artery, your veins compressed over here. Lateral side of the patient, you're entering with your needle, following your probe, piercing through both your fascia lata there on top, as well as your fascia iliaca here. So fascia lata, fascia iliaca, needle going through both, giving a nice pool of anesthetic just underneath that fascia iliaca, which is optimal. That way, giving this 30 cc installation will give you good diffusion or dispersion to both, or to this nerve, as well as hopefully your obturator nerve and your femoral lateral cutaneous nerve, which are the three major nerves that serve the hip and provide pain relief. So why are we doing this? Pain relief, obviously, but also less need for opioids. As we know, delirium is an all too common occurrence in these patients, so less opioids equals less delirium. There's also a trend towards less hypoxia, which is intuitive. You don't decrease the respiratory drive as much as you do with giving opioids, and you don't precipitate pneumonias as much, as well as there's been a trend towards less UTIs. And why? Also because it's fun to do. So when can you do it? You can do it now. Don't forget to give Tylenol, as I mentioned before. Also, make sure you document your exam. Please don't forget to do this. It doesn't have to be extremely fancy. Just document nice distal pulses, sensory and motor exam distal to where you're going to be doing this block. And make sure that you consult ortho. You don't need to wait for this callback. If you do hear anything from orthopedics, please let me know. They're all on board with this. There shouldn't be any issues. I don't think there's been much, other than just to remind you that these aren't blocks indicated for dislocations. That's a different pain modality that you're going to be more of a spasm type of pain. So this is not an indication for dislocations. This is for fractures. So just a reminder for that. Otherwise, have fun with it, be safe, and let me know if you have any further questions. Thanks, guys.